Hello and welcome to the My Dietitian Journey Podcast. My name is Adam, your co-host and producer. With me, of course, Felicia Peraza of Peraza Nutrition and My Dietitian Journey. We've got a chunky episode today, bit of a chunker, as they say. What are we going to talk about today?
We're going to talk about all things Medicare.
Medicare, that's a lot of stuff. Medicare is a lot of stuff. We can just start with the basics. Just jump in right into the basics. What is Medicare?
So Medicare is a federal insurance program. So it's for people who are 65 or older, certain younger people with disabilities, and then people with end-stage renal disease or permanent kidney failure that requires dialysis or transplant. And there's different parts to Medicare. So there's Medicare Part A, which is the hospital insurance. And then there's Medicare Part B, which is the medical insurance. And this covers like outpatient care, preventative services, and this relates to dietitians in private practice. And then there's Medicare Part C or Medicare Advantage, which is offered by private insurance companies. This is approved by Medicare and includes Parts A and B. And then Medicare Part D, which is prescription drug coverage.
So the weird part, the part that's unclear in there is Medicare Part C. We're going to spend a significant time talking about Medicare Part C, aka Medicare Advantage. Those terms are synonymous, basically.
Yes.
All right. So what's the difference between Medicare and Medicare Advantage?
So Medicare Advantage plans or Part C, these are going to be issued by a private insurance company. So an example would be Independence Blue Cross. They have what's called Keystone 65. So that's their Medicare Advantage plan. Aetna Medicare, Cigna Alliance Medicare. So there's all different kinds of options. We're going to have a ton of links in the description, and you can actually search for Medicare plans by your zip code. And so with a Medicare Advantage plan, again, these are going to be issued by a private insurance company. So at a minimum, they're going to have the same benefits that someone who has original Medicare with Part B would have, but they have additional coverage. So one thing that's really important here is that you need to be in network with that specific private insurance company and their Medicare Advantage plans. And then you would submit claims to that private insurance company, not for Medicare, if not directly to Medicare, if they had this Medicare Advantage plan. So I ran into that with Cigna and Cigna Medicare, which I just assumed I take Cigna, I must take Cigna Medicare. But when I did the application process originally, I didn't check the box to be in network with Cigna Medicare. And so I needed to actually apply to Cigna Medicare to be able to take that insurance specifically.
Yeah, we talked about that in another episode where we were talking about taking insurance, not a podcast episode. This was a YouTube video. And we got into a little bit about checking the box for Medicare Advantage when you're signing up when you're credentialing with that insurance company. But if you sign up with Medicare as the first insurance plan, quote unquote, provider, as far as credentialing goes, then it makes it a lot easier to credential with the rest of the insurance companies because you can sign up for Medicare Advantage, their version of it right away. So it's good to start with Medicare when you're credentialing, right?
Yeah, that's definitely
It's a good starting place.
I wish I would have just started there.
Yeah, it makes things easier as you go forward. So why should you take Medicare as a dietitian?
So it's a way to just basically expand your care to patients who may not otherwise be able to receive it. And something I didn't know when I became a provider for Medicare was that if you don't enroll as a provider for Medicare, you can't provide MNT to a patient with Medicare that would have coverage for a specific benefit, which we're going to talk about, unless you formally opt out. You would actually need to refer to a Medicare provider. So if they were seeking services for medical nutrition therapy and had a qualifying diagnosis and you didn't opt out of Medicare, you can't charge them. You have to refer to someone in network. So it is important to note that Medicare only covers for specific diagnoses, and we're going to cover these. So diabetes and renal disease, but there is a formal opt-out process.
So in your practice, I've noticed that we get a fair amount of Medicare patients. And I would say, from my experience, that we bill Medicare, the federal program, about as often as we bill Medicare Advantage plans. I mean, we bill a fair amount of Medicare Advantage compared to just Medicare. Mm-hmm. We don't have a ton of Medicare patients, but it's important, I think, to note that these Medicare Advantage plans, Medicare Part C, it's not like it's a super rare thing. You're going to see it if you're in this space for long enough.
Yeah. And in particular, Keystone 65 is probably one of the more common ones I see. And that's just because there's a lot of in this area and patients that I tend to see that a lot of them do have like independence and then end up going with the private insurance for the Medicare Advantage Part C.
So here's the $1 million question. Here's what everyone wants to know. How much does Medicare pay?
So the fee schedule is public information. This is updated yearly by the CMS or Centers for Medicare and Medicaid Services. And this could actually be a really great place for determining what your rates are and what to negotiate for. So when you're looking at the fee schedule, there's a couple things to keep in mind. So the payment rates and the payment policies are for healthcare providers and for physicians. The fee schedule lists the rates for physicians, and dietitians are paid at 85% of that rate, and that's by law. Also, something important to note is that in 2022, after the pandemic, there was a 2% reduction in rates due to sequestration. I don't know how to say that, but it's basically a mandatory across-the-board reduction in federal spending. So there's another 2% reduction. This was something that was prior to the pandemic. It was like on pause and then they reinstated it. And there's a lot of information about why this is the case and what act and law and all of that. So we'll have a link to that as well. So when you look at the fee schedule, you're going to choose your specific locality, your state, the procedure code, modifier. So it's just some examples. And if you are in private practice, you are a non-facility. So there's a facility rate and a non-facility rate. And then you'll see participating providers as one of the line items too, but you're non-facility if you're in private practice. So a non-facility participating provider, you'll see on the fee schedule, if you were looking at, let's say, Pennsylvania, they have what's called the rest of the state, and then Philadelphia is separate. So the rest of the state, as a participating provider, non-facility would be $35.66. That's what you would see on the fee schedule. But then you have the 85% reduction and then the 2% reduction, which then it would be $29.51 for one unit.
Okay. Yeah. Per unit. So per 15-minute increment.
Mm-hmm. And then like Philadelphia, it's slightly higher. So with the 85% and the 2% reduction, it would be $32.22. And that would be per unit as well. And then the follow-up, and this is the case for follow-ups with most insurances, that you're paid less by follow-up than you are for an initial session. So an example, let's say, of a follow-up appointment, if you were, again, participating provider, non-facility, the rest of the state of Pennsylvania, you'd be looking at around $25.86, again, taking into consideration that 85% reduction and the 2% reduction. So like an hour session follow-up, you might be looking at $103.44, something like that.
So those rates are public knowledge. We're not stepping on anyone's toes, sharing those. You're welcome to look them up. The link is in the description or the show notes for checking for your rate. Now, those rates are what you want to look at and shoot to be above when you're negotiating with other insurance providers. You certainly don't want to get paid less than Medicare. So when you're in the credentialing process, initially setting up your practice, this is another reason to start with Medicare. Start with Medicare and get credentialed with Medicare and then get familiar with their rates. And then when you go to credential with Independence or Cigna or Aetna and so on, be familiar with these rates and make sure that you don't go below them. If anything, try to negotiate for a rate that's a little higher. We can get into negotiating rates in another episode in more detail in terms of how you can leverage that. The short answer is you don't have a ton of leverage as a small practice, but there are things you can do.
Yeah.
Just something to keep in mind when you are credentialing and looking at your rates and negotiating is to use Medicare's rates as a baseline.
And one thing also important to note for collecting payment from Medicare patients. So as a provider for Medicare, you can only collect the Medicare approved rate. So basically what is in that specific fee schedule. You can't charge the patient for any difference between what you charge and what Medicare pays. And that's generally the case with most insurances, is that you can't balance bill unless there is a specific patient responsibility, co-insurance, or copay, which would be on the EOB. In some cases, in some states, there is balance billing that's allowed. It's not something that we could do in Pennsylvania. And also, with, again, commercial insurances, they have clauses in their contracts. So you want to make sure that you're reading that so you're not violating your contract.
So we've talked about getting credentialed with Medicare a bunch. How does one apply to become an in-network provider with Medicare?
So the CMS website, through what's called PECOS, which is the Internet-Based Provider Enrollment Chain and Ownership System. You can also do a paper application, which I would suggest join the online version.
If we're going back in time 30 years, do a paper application.
Yeah, it's but we'll have a bunch of links in the description with all of these different databases that we're talking about. You're going to need your NPI before you complete the PECOS application. And so we'll have a link to that national plan enumeration system. You'll also need just like personal information, like your name, your date of birth, social security number, your license information, if you have licensure in your state, and also certification information, practice information, so your location, your name, your EIN, LLC. So all of those things you're going to need to have set up before you can become a Medicare provider. And then information about electronic claim submission, electronic funds, so to get direct deposits. And this generally takes around 45 days. And again, this is where you want to start with credentialing. One thing I will say with Medicare is, although it's a pretty robust application because everything is done through Medicare, they are very helpful with the process. I have called them before when I was changing, my business information and updating my tax IDs and adding a group NPI, and they were very, very helpful. They actually answered the phone, and someone actually talked to me and walked me through some of the process of what I needed to do. They also have a ton of help guides, which is why you're going to see a bunch of links in the description, because they have actually walk through steps for you. So they do make it as I would say, as seamless as possible. So
you're making it sound like no one picks up the phone when you call. Aetna picks up. They're
That's
pretty
true.
good.
Aetna did pick up.
The ones with the longest wait times, I think Independence is the biggest culprit, but that's one of our most common carriers in terms of when we bill. What does Medicare cover?
So the nice thing about Medicare is they're pretty straightforward with their coverage. So for the first year, a patient, which if you're looking at stuff online for Medicare, they refer to the patient as the beneficiary. So the first year that they receive MNT, they have 3 hours. And they need to have a diagnosis of non-dialysis renal disease or diabetes. And you can actually find all of the ICD-10 codes listed on the Medicare website. And we have those linked as well. After the first year, 2 hours are going to be covered. So again, 3 hours for the first year, 2 hours for follow-up years. And one thing that's also nice about, with the hours is that dietitians, we can choose how many units are going to be for each appointment. So it's not like you have to do an hour-long session and, a follow-up session at a half hour. You can have an hour session and then a 15-minute appointment. And again, there is a specific set of ICD-10 codes that are covered, and these are for, again, renal disease and diabetes. Medicare also does cover 97802, which is the initial face-to-face MNT for an individual, 97803, which would be a follow-up session, and then also 97804. And then there's also something called a G code, so it's G0270. And this is basically for MNT, which we're going to talk about this as well, a reassessment. So if a patient needed another referral for additional visits, you would use this G code in particular.
Medicare does not cover heart disease.
Yes.
They do not cover obesity. They will only pay you if your patient has a diagnosis code for kidney disease and or diabetes.
Yes.
They do not cover anything else, not even heart disease, which is absolutely crazy. And hopefully that changes. If it does, I will put a pinned comment down below correcting this information, because there is some progress in terms of getting them to cover heart disease or hypertension or something.
Hypertension, heart disease, like the cardiovascular disease, obesity, eating disorders. So there's some progress being made as to trying to expand the coverage for Medicare, but at this point, it is just diabetes and renal disease.
It's June 14th, 2023, and as of right now, diabetes, kidney disease, that's it. It's bonkers that's all they cover. It's absolutely crazy, but that is the truth. So does Medicare cover telehealth?
Yes. So at this point, they cover, for telehealth, they cover also audio-only interactions. And this is, again, they have specific telehealth modifiers. 95 is the one that you're going to see. So that's the synchronous telemedicine, real-time audio and video. There's a telehealth code lookup that Medicare has. So again, all of this information is very accessible on their website. So the modifiers are listed, but also you can actually look per CPT code what specific, if the telehealth is covered, and in their spreadsheet for 2023, 97802, 3, and 4, and the G code are all covered for telehealth as well.
That's a really unique aspect of Medicare, that they cover audio only. Essentially, you can have a HIPAA-compliant phone line and conduct sessions.
Yep.
It's very unique to Medicare. As far as I can tell from any other provider, from any other company we work with, that's not acceptable.
Yeah, and they might take that away. I'm not sure if they had that before the pandemic. With certain insurances, like Highmark and Independence, at one point they were also covering audio only for dietitians. Actually, Independence, I think, still covers it for behavioral health providers for audio only. So they do cover phone sessions. They took it away for dietitians and the CPT codes that we would utilize, which we ran into that issue
That was
year.
an issue we ran into early on more than once.
Yes.
So if you happen to be a behavioral health care provider listening to this, watching this, feel free to reach out. We're interested in branching out a little more and getting involved in providing the services we provide for dietitians, but also for other healthcare providers. We know there's a lot of behavioral healthcare providers out there. So if you happen to be in that discipline, feel free to reach out. We may be looking to take on a case study, which means that we would basically help you launch your practice and do all the things free of charge, because we're trying to learn. So if you're up for that, if that's something, obviously we would probably interview you for a case study to see if it's a good match. But we are in the market to expand and learn some more stuff about behavioral healthcare providers. Okay. Can a patient get extra visits with Medicare?
Yes. So if they're considered to be medically necessary, and if the physician determines that there is a change in a medical condition, diagnosis, or treatment regimen that would require a change in MNT, and then they can order additional hours during that year that you would be working with that patient.
I guess I should also note that we would work with a speech therapist, an occupational therapist. We're not just looking to work with behavioral therapists.
Yes.
What I was just talking about. But there are more behavioral therapists than anything else.
Yeah.
I'm noticing. What do you need to have when getting a referral for a Medicare patient?
So Medicare, you need a referral. That is something that's required. And when you get a referral for MNT for Medicare patients, you need to have a referring physician, which needs to be a MD or a DO. NPs or PAs, they can't be referring providers. And you need to have the referring physician name, NPI, practice information, the patient's name, their date of birth, that it's for MNT or nutrition counseling, or the CPT codes, and then specific ICD-10 codes. You also do need a new referral every year. And if you're again looking to get additional visits covered for Medicare, you would need a new referral as well. So the referral is going to be really important. And we've talked about, with certain cases, if you need specific ICD-10 codes, you can, just get medical records or, a note from the physician. With Medicare, you need a specific referral, so a referring physician, because that information has to go on the claim that you would submit to Medicare or to the Medicare Advantage plan.
So this is somewhere that a dietitian, you may run into a problem here if your patient's primary is an NP. they can't write the referral for this. That could be a problem. We've had some patients where their primaries are NPs.
Yes.
Not for Medicare patients, but that does happen. That's getting more and more common too.
Yeah, and especially for their their primary being an NP, and so in those cases, if there isn't like a physician in the practice that's willing to write the referral, like the endocrinologist or the nephrologist, if they have kidney disease, those are usually the ones that end up writing the referrals. So I actually have, I think, more recently, more referrals coming from the endocrinologist than anything else, and they're pretty good about. We haven't run into any issues with the specialist writing the referral.
So what's the difference between having Medicare as a primary insurance plan and Medicare as a secondary?
So if a patient has Medicare and then another health plan, there would be this coordination of benefits rule that basically applies to who would be paying first. So the primary payer is the insurance company that's going to pay first, and then the remainder of the bill would be sent to the secondary. Now, one thing it's important that you need to know is that you need to be in network with Medicare, like original Medicare, to bill them if they are the primary. Now, the secondary insurance, again, is going to be the payer that's going to pay if there's additional costs that the insurance didn't cover. But in some cases, that secondary insurance may be a supplemental plan and not actually cover what Medicare does not. So if a patient doesn't have like a full secondary plan or has like a supplemental plan, then if Medicare denies a claim or doesn't cover something, then the secondary plan will not. So there's examples. Let's say a patient has Medicare, maybe they're retired, but they are covered by their spouse's plan, like a commercial plan, and it's a full plan. And their commercial plan, let's say if it's Independence Blue Cross, like Keystone Health Plan East, let's say that's their primary and Medicare is their secondary, you would bill the commercial insurance first because Medicare is secondary. Now, if they were retired and they were not on a spouse's plan and they had Medicare primary and then they had a supplemental plan through this commercial insurance, a lot of times those supplemental plans don't actually pick up the extra costs, at least for dietitians that I've noticed. So if a patient is like, I don't know which one's primary, which one's secondary, which has happened to me before.
That happens all the time. You wouldn't believe people just throw you cards. When I did my internship at a doctor's office, it was like, they don't even know they barely know what medical insurance is.
That is very true. And it's funny because I was like, I don't know which one is your primary or your secondary. Like, how was I supposed to know? It doesn't say on the cards, like, this is your primary and this is your secondary. So if they're not sure, actually, they can just call Medicare. There is a specific benefits coordination and recovery center line that they can actually call and figure out if Medicare is their primary or their secondary. So yeah,
it may come to you making that phone call also. If it's like a super old person that struggles with this stuff, that may be what you need to do. This is part of the homework that you do before you have the appointment. We have clients that we work with, dietitians that we work with, and sometimes they get into a bit of a mess because they see patients before figuring this sort of stuff out. So this is one of those things where you get it straightened out. You know what the primary is, you know what the secondary is, you understand their coverage better than they do, ideally, before you see the patient.
Yeah. And one thing too, when we're talking about coverage and, billing the primary and billing the secondary, there's actually, Medicare has a help guide on this as well. So I feel like they have a help guide for everything. But when you are working with a commercial insurance let's say they have a Medicare Advantage plan, and we talked about, you're going to bill that Medicare Advantage plan in particular, and not bill, original Medicare. The guidelines that we talked about in terms of what Medicare covers, they may not have additional coverage beyond that for medical nutrition therapy. So I've often gotten misquoted by representatives when calling that say that the patient has, 6 visits, but in reality, they don't actually have those 6 visits. They have a Medicare Advantage plan, and it's very clear as to what that coverage is.
And that's something where you'd have to be ultra specific and kind of know what questions to ask, and then get very specific information that pertains to that particular plan.
Yes.
There's no generic, it's 6 visits per year.
Yeah. Yeah. And we actually covered independence in particular in a past video that is on the channel.
We did.
And Medicare too on there, the Medicare Advantage piece.
We mentioned there. Okay. Yeah. Oh yeah. We go through all the policies and stuff on camera. You can see the policies and we link to them and stuff too. I can link to that video. It's one of the most recent uploads. So what do advanced beneficiary notices have to do with Medicare?
So ABNs, these are written notices that are given to a Medicare beneficiary or the patient before, this is important, before you provide a service, when you believe that Medicare probably won't or definitely will not pay for a specific service. And again, it has to be given before the service is rendered. You have to obtain this notice on file, and you actually have to get a new ABN each year and then retain it for 5 years after you finish delivering whatever the service is, or if there's a specific state law that requires you to hold it for longer.
Who provides this ABN?
So the ABN would, so there's a template for the ABN listed on Medicare's website and actually a whole help guide as to how to fill it out. But it would be given by you, the provider. So, for registered dietitians, we would actually give this to the patient to fill out.
And how do you fill that out?
So you're going to need your name, your address, your telephone number, the patient's name, the specific service, and then the reason that Medicare may not pay and the estimated cost for the patient. It is very clear. This form is like a fill in the blank kind of thing. And then the patient has to check one of 3 options. So basically the one option is they want the service and they want Medicare to be billed, and they understand that they will be charged if Medicare does not cover it. 2 would be they want the service but don't bill Medicare. And then the third option is they do not want the service, which is why this is so important to give to the patient before you actually have the appointment. And then the patient would sign and date it. And there is a whole help guide from Medicare on the specific instructions with the ABN. But again, the patient has to be the one clicking off those boxes, and you have to make sure that your specific rate is on there as to what the patient might pay if Medicare does not cover it.
So do you care to expand further on exactly how these factor in with billing?
So when you're billing, and this is where the modifiers come in, because there's actually specific modifiers for the ABN. So the most common ones that I've utilized are the GA modifier and the GZ modifier. So the GA modifier is when you issued a mandatory ABN and it is on file. And if you're ever audited, you're going to need to make sure that you show that there's this ABN.
What is the end purpose of an ABN? What is the function of this document?
So it's basically notifying the patient that there's a service that Medicare may or may not provide or cover. So the whole point is you have to notify the patient that they might be expected to have an out-of-cost payment, or that they have the right to deny having that service if it's not going to cover.
Out-of-pocket payment? Like they may have a patient responsibility?
Yes.
Okay. And this doesn't factor into maybe having it covered potentially by their secondary, or this isn't a way to get Medicare to cover other diagnosis codes.
Yep. Yeah. This is like if Medicare is primary, you have to have this ABN, even if you're going to be ending up billing the secondary insurance, which when you would fill out the claim submission, you would have on there the primary insurance and the secondary insurance, and it would be sent to the secondary insurance to see if there would be coverage. But again, if it's not a full plan, they're not going to cover it anyway, but you still have to have that ABN on file. And the GA modifier in particular, you would need that to be able to then bill the patient. And if the claim was denied, like the line item would say that it was under, basically not medically necessary. And then there's a GZ modifier, which is the other one, is when you basically are expecting Medicare to deny the claim, and there was no ABN that was issued, and then the patient is actually not responsible for the payment. So Medicare usually auto denies any like GZ modifiers. The GA is the one that I've used. I haven't used these super often, but these are the modifiers that if, again, you are expecting Medicare not to pay for something in particular, and you might use this, let's say if you are billing, you need to bill the primary to get to the secondary insurance. This is where you might be using one of these modifiers and this ABN, and you would have this on file, because then if it gets to the secondary insurance and it's also still denied, you have that ABN to then be able to actually bill the patient.
So part of the thing with the ABN is, so let's say you're seeing a patient, they're over 65, they're on Medicare, but they're willing to pay out of pocket. You still have to do this.
Yes. So you have to do this, and they would check off, let's say if they have heart disease and it's not a covered diagnosis, I would let them know, Medicare doesn't cover for heart disease, for medical nutrition therapy, at least not at this time. And so here's what the service cost would be. And let's say, I say, it's going to be $180 for the hour. And they're like, I'm okay with that. I really need this service. I would have them sign that ABN. And in theory, they should be checking off that second box that says that they understand Medicare is not going to pay and that they do not want Medicare to be billed. That way you're not billing Medicare. You're basically going to bill for a denial. But in some cases, I've had patients say like, oh, just bill it and we'll see if it gets paid. If not, I will pay it. And that ABN is on file for me to be able to do that too. If
someone's on Medicare, they want to see you. Mm-hmm. They have a condition that is not covered by Medicare, heart disease, let's say. Mm-hmm. You would need this ABN on file in order to see that patient, for them to then self-pay and you not get into any issues legally or with contracts or anything like that.
Yes,
This absolutely. Is a required step for that.
Yes.
Okay.
Yep.
Yeah, it's the same sort of, I want to learn more about behavioral healthcare as it pertains to insurance, and I'm just trying to draw some parallels here. So you're not actually allowed to just willy-nilly bill a patient self-pay if they have independence and it's covered. Even if they're beyond their visits or whatever, you can't.
If they're beyond their visits, absolutely, because at that point it would be a non-covered benefit. Like if you bill the insurance, it would say that the visits, they have no more visits, basically, in formal terms. But if let's say there is specific criteria for diagnoses that there's coverage for. So like Aetna has very specific ICD-10 codes, and let's say they don't have any of those conditions, that in that case, you're in network with Aetna, but the service isn't going to be covered by Aetna. So you can absolutely do self-pay. Or if you're doing something that's not a covered service, like we're talking about medical nutrition therapy, but let's say you're doing like a cooking class or something like that, that's where you could bill a patient and has nothing to do with insurance, because that wouldn't be something that's covered with the insurance as it is.
Yeah, I kind of drug us off topic here a little bit, but I just wanted to make sure I understood, and that I was asking a good question here for these ABNs as they pertain to Medicare patients, because this is where you're going to run into it. This is the least flexible plan a patient could have in terms of coverage for things, because a lot of patients don't have diabetes or renal disease.
Yeah, unfortunately. And more often than not, we've gotten some recent calls that were patients that had Medicare and didn't realize that they needed to have diabetes. Pre-diabetes, also not covered at this time. And that is also very frustrating. And I've had phone calls with potential patients where they call and they're like, I have pre-diabetes. And I'm like, unfortunately, it's not a covered code, for Medicare, yada, yada. And they're like, so I have to be sicker to be able to work with a dietitian. And I'm like, unfortunately, I don't make the rules, but
that's the way it is. It's unfortunate, but that is the way it is currently.
Yeah.
So, okay. That's, I think that sort of wraps us up here on Medicare. It's not exactly a long episode here, but it's very dense.
Yeah.
So this is one of those things where it kind of pays to take a few notes and maybe re-listen to certain things for this one. Medicare it's a lot to learn in terms of the fringe aspects of what they do and how it works. But basically the short version is, if they're over 65 in the United States, they're on Medicare. If they don't have diabetes or kidney disease, you're probably not going to be able to bill.
Yeah.
So more often than not, when we get patients who call, and I'm the one calling them back these days, usually the conversation involves asking them what their coverage is and why they want to see you. And if it comes to them not having diabetes or kidney disease, you're more or less like, hey, sorry, you're not covered for this service. But, at that point, that's when you go to an ABN and then out of pocket and blah, blah, blah. So that's, kind of where all that factors in.
Yeah, definitely.
So that, I guess, will wrap us up here. Any final thoughts, closing thoughts for Medicare?
The only closing thought I would have is just there's a lot of information on Medicare's website, and there's a lot of really good information and help guides. So definitely utilize those. It is, again, like a lot of dense information. Also, one thing we didn't know about billing is we 100% recommend using your billing platform. So if you're using an EMR, we use Simple Practice. Definitely bill Medicare through those platforms versus their new system.
Yeah, it's the weirdest thing. So they recently changed systems. It's like a year or two ago. And they make you download this program that looks like it's from, if anyone is older than like 30, 35, that's used a computer since early childhood maybe, or if you're over 40, you probably remember Windows 2. This is like before Windows 95. That's what this program looks like. It looks like it's from Windows 2. From the 90s. It's bizarre. I've never seen a program come out as quote unquote new with a user interface that looks like it's straight up 30 years old. It's really strange. The program is super cumbersome. I hate it.
Yes.
With a passion. And it involves, you have to export a document and import it into a website and send that. It's like you're practically becoming a computer programmer just to bill Medicare through their program, through their platform. So the way we have circumvented this is we use Simple Practice, and you just send it to them. You're just like, here you go. Have fun with this. Do whatever you do. And it gets paid.
Yeah.
Yeah. If you use Practice Better and Office Allies, same deal. That's one of the major benefits of having an EMR and a full package in terms of how that goes. You can pay them to do your billing and stuff. It's much easier in general, but also a world of difference with Medicare, especially.
Absolutely. When I first started with Medicare, they had their system was like just embedded on what's called Novitas-Sphere, and that was pretty simple to use. It was just like a fill-in kind of thing with most insurances, and so it wasn't anything weird. And it made it more complicated. And we've submitted claims using their archaic looking software.
We've tried.
And they literally were submitted and they never went anywhere. Like I couldn't find the claims afterwards. It was just a nightmare. It's like, we're just using Simple Practice for this.
And we spent some time trying to learn this platform too. And we're in our 30s. We've been using computers for a long time. It's not like we don't know how to use a computer. This is just a weird, archaic is a good word for it, program that I would recommend avoiding at all costs.
Yes.
But if you know how to use it and you love it, more power to you. You know
Definitely.
What? Go for it. Not for us. All right. I think that's going to do it here. Thanks for listening. Tons of links in the description. Check out the channel on YouTube if you have any concerns about things like NPI or EIN. We mentioned those earlier in the video. And please do, if you're curious about policies and Medicare Advantage in particular, we spend a significant time delving into Independence's in Medicare Advantage program in particular. And in the future, we will be doing more analysis videos of different policies for other major insurance providers, probably Aetna, Cigna. They're the ones that we're going to look at next. So if you're interested in that at all, please do check that out. And as well, if you'd be so kind, slam that like button. What do they? Smash the like button?
Smash.
Yeah, whatever. It's there's a very fringe, very specific group of people who watch this stuff. And we appreciate you being here, and we hope this is helpful. But if you would be so kind as to interact with the interactables on your respective platform, that would be great for us. But that is going to do it from here at the My Dietitian Journey Podcast. Check out the 1,000 links in the description and leave a comment if you have any questions. Otherwise, thank you for watching.